talk us about HPV infection and tuberculosis.
Thank you so much for the invitation. Such great talks. Congratulations to the speakers previously. If we can start my presentation. Okay, so as a last talk, we will talk about two clinical entities. One is quite rare, the other quite common, but nevertheless, they're both debilitating for our patients, and we must know how to identify them and treat them. So I don't have any financial disclosures, and we will start with the human papillomavirus. It is a very common virus, and other specialties are really much interested in this, like genitourinary tract is most commonly involved. As regards respiratory tract, it is a rare manifestation, but when we have symptoms from the respiratory system, the cases can be quite severe. So laryngeal involvement is the most common, but we also have tracheal involvement or bronchial involvement, and when we have this, we have central airway obstruction. The HPV incidence is rising due to the HIV epidemic, so we must be aware of this in our patients. And this disease is very notorious to be resistant to treatment. So why we have to be extra careful about these patients? Because when we have HPV in the respiratory system, it has been shown that it is associated with squamous cell carcinoma. In this study, which is a pathology study, they took about 2,500 samples and they tested them for HPV DNA with several methods. And they found that actually in 20% of these samples with squamous cell carcinoma, there was HPV DNA present. So it's not that uncommon. They found that the subtypes 16 and 18 were predominating, but also the most common types of 6 and 11 were demonstrated in these tumors. So before we start talking about bronchoscopy, first we must consider imaging. Because it's our first modality, we always have imaging before doing any bronchoscopy. The most common image you can see is obstruction of the trachea and the main stem bronchi from tumor-like masses. But reality is not always that simple. In this study, quite some time ago from Brazil, they had 8 patients, and these patients had a human papillomavirus and tracheal and bronchial involvement for quite some time. They had several procedures, and most of them had, of course, tracheal involvement. But what could be seen, or at least 7 out of 8 patients had also parenchymal lesions. So we can find cystic lesions, areas of the bronchi destroyed, and sometimes these cystic lesions come together and form larger cysts. So before considering any bronchoscopy, we must also have the appropriate imaging. Of course, bronchoscopy is the mainstay of diagnosis. So when we get into the trachea and the bronchi, we can see this cauliflower-like appearance, and we take biopsies, and we have the assurance by the pathology that we have these papillomas. Papillomas look like this. They have a fibrovascular course, and they have a squamous metaplasia. So when we take the biopsies, we must always have in mind that if we use procedures such as electrocautery or laser, the plume that is created can be quite infectious to the bronchoscopist and the staff as well. So we have to make sure that we have the adequate precautions. The differential diagnosis is quite wide. As you show, there are many entities affecting the trachea and the bronchi. Of course, we have malignant lesions, deposits of nodules from renal cell carcinoma, from thyroid cancer in this case, but also the other entities that we have already discussed. We can say that for this rare entity, the nodules are quite hard and they're calcified, so it's quite clear that they're not papillomas. But with sarcoidosis, we cannot be that sure because the lesions are quite similar. Of course, sarcoidosis has a more homogeneous pattern, and we can see, we already heard that stenosis is possible as well, and the treatment is completely different. Amyloidosis, we already saw such a case, has a more diffuse involvement of the trachea and the bronchi. Usually it's straightforward, but amyloidosis is very rare as well in the trachea and the bronchi. We already know our tools. We can use electrocautery. If you could play the video, please. I'm not sure if it's, sorry. Can we go back 3 slides? One more slide, please. No, not there. More back, 2 slides, one more. Okay, we have a video here. So we have the contact mode, which is electrocautery, and we can take biopsies with electrocautery forceps. We have snares for larger lesions, and for hemostasis, we have argon plasma coagulation. It is a non-contact mode. We eject argon plasma on the hemorrhage, and we can have a good management of the bleeding. Some sites, usually in the US, use also this microdebrider, which is ENT tool mostly, but it is adapted also for bronchoscopy use. It has this fenestration that you can see with a serrated rotating blade, and it cuts through the papilloma and actually debulks. And some physicians prefer this because it doesn't produce a plume, but of course it's quite hemorrhagic. If you could play the second video, this is one of our cases from the lab. So you can see that the lumen is obstructed at least for 40%. The papillomas are there. The first step, of course, is to cauterize them because they're bleeding. And slowly with the rigid forceps, you can see that we can debulk and take biopsies. And as a last step, of course, we have to cauterize them and stop the bleeding, just to be sure. Another method to deal with papillomas is cryotherapy. Cryotherapy is based on releasing a gas, usually nitrous oxide, through a small catheter at the end of the bronchoscope and creating temperatures less than 40 degrees. It is called the Joule-Thomson effect. We can destroy papillomas in the slow way, as you can see on the picture on the right. We can apply sequentially in every spot the cryoprobe with freezing and thawing cycles, and thus destroying the papillomas. This is quite slow. Or we can use the cryo extraction. If you can play the video, please. Βάλτε λίγο το video. So cryo extraction is a little bit different. You apply the probe directly on the lesion, and when it's frozen, you ensemble together the scope and the probe, taking large chunks of tissue outside the lumen. Of course, we must be ready to, immediately as the thawing process starts, to get the bronchoscope inside and control the bleeding. So, additionally to our usual modalities, we have some systematic administration of certain agents. It has been trying interferon, acyclovir, retinoic acid, ribavirin. They have or EGFR inhibitors. They have mixed effects. As it was mentioned in previous talks, we have also local administration, bronchoscopic administration of certain agents, such as intralesional cidofovir or bevacizumab. So cidofovir has been tried on laryngeal papillomatosis in this study. There are only anecdotal uses on papillomas on the trachea and the bronchi, but it seems to be effective. It reduces the load of papillomas, as you can see in the picture on the left side, but unfortunately there are relapses. So only one of these 10 patients had a long remitting condition. All the others had to undergo again bronchoscopic procedures. The same applies for intralesional bevacizumab. This has also been tried to laryngeal as well as tracheal papillomas. It is very readily available because it is an oncologic treatment, but this is an off-label use. There are no studies. It seems that it helped to increase the duration between bronchoscopic treatment. This is a study in children, and it improved quality of life in many aspects. This may be a medication that we can use in randomized trials in the future. Photodynamic therapy has been tried, again with mixed effects. Initially, the response is quite good, but afterwards there are a lot of relapses as well. In Greece, it's very difficult to do photodynamic therapy because we have also the sun exposure. So let's finish with the HPV and let's go to a more common problem, which is tuberculosis. Tuberculosis is always in the focus because we have a lot of patients around the world. 1.4 million people died from tuberculosis in 2019, and there is inadequate control of tuberculosis all around the world, especially in the era of the COVID pandemic. And we have a lot of multi-drug resistant strains which are present, and they are a public health crisis. So endobronchial TB is, due to our effective anti-tuberculosis treatment, it is more or less declining, but it's present. It seems that 42% of the biopsies, in 1,000 biopsies of patients with tuberculosis, we can see endobronchial TB. And it seems that when we do not recognize and treat it appropriately and on time, it can lead to airway stenosis. There are certain theories about the infiltration through the blood vessels or the lymph nodes, the lymphatic vessels. The clinical course can be variable, and usually it's more frequent in women in the second and third decades of life. So it can be a great mime. It can cause ulcerative whitish plaques and necrosis. It can cause exophytic mass, which can look like a malignancy. And of course, it can look in this way in the post-TB airway stricture. This is one of our cases. It was a 28-year-old female. She presented with a long-standing fever for weeks and cervical lymphadenopathy. She had a Mantoux examination, which was positive, a quantiferon test, which was positive as well. Her CT scan had 3 bud infiltrations in the right lower lobe, as well as lymphadenopathy in the mediastinum and the right hilar region. So when we did the bronchoscopy, we were surprised to find that she had also an endobronchial aspect from which we took biopsies, and we did, of course, EBIS-TBNA from the subcarinal node. And the result was that pathology showed that there is caseating granulomas from the lymph node, and Thiel-Nielsen and Levenstein-Jensen cultures were positive. We were also surprised to see that she had a mutation for the isoniazid response, a CAT gene mutation, so we were forced to give her an alternative treatment to the classical and for much longer period of time. These are 2 Greek cases where pulmonary tuberculosis coincided with actinomycosis. Actinomyces is a gram-positive bacterium, and of course it is not a very common endobronchial manifestation, but we had at least 2 cases published here in Greece where we have actinomyces along with pulmonary tuberculosis. In both these cases, we had these whitish exophytic lesions which were actinomyces, and of course the positive Thiel-Nielsen. So let's go and talk a little bit about post-TB airway stenosis. We have patients that present, they look like asthma, dyspnea, and wheezing, and when we do the imaging and when we do the bronchoscopy, we find out that they have the strictures, and it could be post-TB. How can we treat them? Usually we use the electrocautery knife and do the radial incisions as it was shown in the previous talks, and then we do the balloon bronchoplasty and we open the lumen Of course, in relapsing cases, we can use a stent placement. In this study from Korea, there are a lot of patients who underwent balloon bronchoplasty. You can see in the picture on the right that we have a significant improvement of lung function testing after balloon bronchoplasty. But as you can see in the picture on the left, when the lesion was less than 2 centimeters, the results were much better. This is a Kaplan-Meier graph, and it was shown that in less than 2 centimeters, the patency remained for longer periods of time. When the stricture was more than 2 centimeters, there were a lot of relapses. And when we have relapses, we must deal with it and probably use a stent placement to maintain patency. Cryotherapy is available and very effective for endobronchial TB. This is a Chinese study. They randomized groups. They found out that in 76 patients, they had endobronchial tuberculosis, so they gave antituberculotics in the control group, and they used cryotherapy for the lesions plus antituberculosis and antituberculotics. So they did a mymin cryotherapy for 4 times approximately, and they found out that the group that was treated with cryotherapy did not develop any stenosis. On the other hand, on the control group, they had to do cryotherapy in 9 patients to maintain patency of the airway. So cryotherapy is an option. So how can we predict which patients with tuberculosis, endobronchial tuberculosis, will develop stenosis? This is a study from South Korea, and they found out that the first and most important factor is that stenosis per se is an independent risk factor. So there are some people that have this genetic trait to have fibrostenotic endobronchial TB. The other one was the delay of treatment. If we do not find out that it is endobronchial tuberculosis, we don't give the treatment on time. So there are more studies on the genetics of post-TB airway stenosis, and in this study, it had been shown that this MMP1 polymorphism was studied, and they found a genotype that actually affects and predicts whether somebody will develop endobronchial tuberculosis and then stenosis. Why? Because the matrix metalloproteinases are very much involved into tissue remodeling. So they found out in the study that if you had this genetic trait, 1G genotype and female gender, were a good candidate for strictures and after endobronchial TB. We can see this also in their histology samples because this MMP1 activity in the 1G genotype patients, it was much, much higher, as you can see in the picture on the left here. So additionally to TB, now we have COVID-19, and during the pandemic, there are a lot of activity mentioning what will happen with TB inside the pandemic because it's truly an epidemic. This is a letter to the editor from the Global Tuberculosis Network TB and COVID group. So this is a warning that there are a lot of patients who have TB and COVID at the same time, and we are not sure how COVID-19 disease can affect the triggering and the reactivation of TB. In their study, 9 patients had in the same week diagnosis of COVID-19 and TB. So they're mentioning that this is worth investigating. There is a second Italian study, also a letter of the editor, who mentions exactly the same. So COVID-19 patients can be at the same time infected with TB. And in this case, they had also 5 of their patients had a drug-resistant strain. So to finish, we have to be sure about what our policies are about TB during the pandemic. We must allocate resources. COVID-19 is present, we know that, but we also have to allocate resources for TB. And this is an example. This is the university hospital in the University Department of Pulmonary Medicine where I trained. It has a special unit for TB. diagnosis and treatment. This unit was immediately transformed into a COVID-19 unit. And this is an example of how we must move forward. We cannot have just COVID-19 units, we must also deal with TB. And I was thinking about it, I was very much surprised, and this is my last slide, that WHO sent me a Viber message in the morning telling me that tuberculosis and COVID-19 are here, and they sent this nice video. I have the YouTube link for you, where you can see how we can prioritize treatment of both these clinical entities. And with that, I would like to thank you for your attention.
Can you see? We'll see this, the video or questions?
No, I was surprised when I finished my talk. I was just reviewing my slides, and just wanted to be sure what I will tell you. I received this Viber message, and it really shook me, because WHO thinks about it, and I think it's very important that we had this talk, and have in mind that we must convince regulatory authorities, we must convince the hospital administrations that we must allocate resources for TB.
Philippos, excellent talk as always. Thank you.
Thank you so much.
Is there any